I would like to try and do this evening is give you kind of a brief update on the endocrine and neuroendocrine tumors book, and then also some of those related to the head and neck tumors. However, I'm really going to focus on the neuroendocrine topic specifically because that is one of the areas in which we have certainly had the greatest change with this particular edition. I do get book royalties, and of course, since I am presenting in the context of the World Health Organization classification books this evening, I have stood on the standing editorial board for that, for the fifth edition, as well as serving as an expert member for the board for both the head and neck as well as the endocrine and neuroendocrine tumors. So, if you don't know what the names of something are, then you don't really know anything about them, and the knowledge of them is lost as well. This was a quote from Linnaeus, who, as you know, was the first one to come up with a hierarchical system of botanical identification. And so if you think about what we do today, if you give the correct name to cancers, then you're ready to be able to go on the mission to defeat them. And so with that, just historically, the WHO has been around since the 1956 when it was originally put in place. To develop the classification system as an evidence-based classification for all cancer types, underpinning whatever is going to happen with the patient treatment, as well as research into the aspects of causation and prevention, therapy, and education. And I will say, having served now since the year 2000 on these various organizations, they are definitely not just for pathologists. I think the pathologists are the primary authors, and certainly many of us use them, but they definitely are utilized by a wide variety of other people as well. One of the things for the fifth edition was really to try and develop better governance for the entire World Health Organization classification, coming up with better quality standards and metrics, and then, of course, a faster production line than what is usually present. You will notice just from the better governance, more than 2,500 authors were involved in the fifth edition, with several links now to other organizations for coding and staging, the genetics as well as implementation of those findings, among others. So this means that the ICDO actually links now with the World Health Organization so that when new entities are described, it automatically would go in for an appropriate coding. Same thing with the UICC and AJCC as far as staging. And then there was a major emphasis on trying to create this as a huge database. So if
Dr.
you talk
Thompson,
about
Dr.
squamous cell
Hale, I'll go
carcinoma in one
ahead and
location
allow the
within
audience
a
in
book, it's
now.
going to be the
Just
exact
wanted to
same
give you guys a heads
identification
up.
and parameters that are required for the
Perfect. Thank you,
diagnosis when it
Yamara.
occurs in other locations as well. And then trying to harmonize across the entire series. So in other words, no matter whether it is a book on gynecologic lesions or liver, that the same terminology is used throughout. And this is specifically related to neuroendocrine tumors, hematolymphoid, soft tissue melanocytic, and the familial syndromes, and hence the reason for me trying to focus now on that neuroendocrine type classification. There was also an emphasis on trying to get linked references that people were able to look at if they were utilizing the online facility. Approaching this in a more global phenomenon. So many times the books have been written from either people in Europe or the United States, and therefore the global epidemiology was quite frequently lost in that particular setting, and this was a nice opportunity to expand that. And then, of course, this is the first time that the website has been utilized, and trying to have an interactive website, which means people are able to save things to it, they're able to make comments, and more importantly, they're able to look at the images, drive virtual slides, and actually link out to the various references that are there. So this is the first World Health Organization book I was involved in 2003. You can see that there were 5 editors involved. We all got to go to Lyon and stand outside together. Yes, I looked slightly younger than I do now. And then the next one came around in 2017. So you'll say, wow, that was, a super long time frame between those particular books. And then we leapt into the pandemic, and of course the entire meeting was all held virtually as we went through multiple different editorial board meetings in order to be able to come up with the classification. Now, I'll tell you, if you talk about too many people involved, well, there definitely were. There were 29 expert editorial board members for this, where you can see there were only 5 people involved in the fourth edition. So it really was a massive expansion of the number of experts on the editorial board in order to be able to lead the book. You'll notice I've highlighted 5 individuals who are in yellow. Those of us actually were people who served on the entire editorial board for the full 6 years, which meant that if there was going to be a discussion about a neuroendocrine tumor as it occurred in the lung or the GI tract or somewhere else in the body, that we would also have input from members who were involved in the other books so that the same terminology was going to be identified throughout. So I do feel that that particular integration was a very nice feature in this particular book. 128 entities, hierarchical classification. So if you think about the previous book, it used to go from malignant and not really why the first malignancy was there to ultimately include some other benign lesions and maybe even some reactive conditions. So in this book, we decided hamartomas or reactive tumor-like lesions were listed first, then the benign tumors, followed by the uncertain or borderline lesions, and then finally ending with malignant tumors, and theoretically at least presenting them in order of low to high grade, although certainly with some things like salivary gland tumors, etc., it isn't always possible to kind of give a separation of which one is, more aggressive than another, and so they may have just been presented in order of frequency. So again, one of the major changes here is trying to aggregate things across the entire organ system. So within the neuroendocrine and endocrine organ system, neuroendocrine neoplasms in non-endocrine organs were aggregated together. All the soft tissue lesions were encompassed in a single chapter. Same thing with the hematolymphoid proliferations and neoplasms. Germ cell tumors, mets to endocrine organs, and then incorporating 15 syndromes in which the endocrine organ lesions were the major manifestations of that particular tumor syndrome, and hence it was presented in this book. As you know, the last book in the edition of this particular fifth series is going to be on familial and inherited diseases, and therefore will encompass a whole wide variety of them for all over the body. I do feel that the online access is fantastic. I've put up the URL in the top corner, so tumorclassification.irc.who.int and then /home. It's about $120 US or thereabouts for an annual subscription to all of the 15 or 16 books that are included in the series, and therefore I feel it's a very good value for people to be able to have access to the entire system. So in this example, obviously we're going to talk about the endocrine.
Recording in progress.
I am really embarrassed to say that it is still in beta version. The reason I point this out is I'm still doing galley proofs as of this weekend, so the book print version is not yet out, but I'm assured it will be out in January. Connection. So some of the best features I feel are that there's kind of a whole slide for every one of the diagnoses. So I do feel this is a very nice integration of current technology, which means you're able to look at a slide that the person who wrote that particular section or is considered to be an expert in that field has hosted. All of the references link through to PubMed ID numbers. So this means as you're reading the book online, you can just click on it and it will automatically launch into PubMed to allow you to be able to read the source material from which that particular clause or phrase was drawn. And then finally, because it's an online database, you can have a whole lot more images in the online version than ultimately will be in the book. Even though at least at this particular juncture, the Endo book is still a single volume. So I'm not going to go over all of the things. I am going to just highlight a couple here and there, and then I'm going to go into one of the newer entities that was added in this particular edition under the thyroid group specifically. I'm not going to try and go through, adrenal and pituitary and all of the other things. It would just be impossible. So as you know, the non-invasive follicular thyroid neoplasm with papillary-like nuclear features was included in the previous edition. There have not been any changes specifically to it, although the criteria have been honed a little bit more. Now you're allowed to have tumors that are more than 4 centimeters in size, and you're also allowed to have tumors that are less than 10 millimeters or 1 centimeter in size. So with the original criteria, those two were excluded because we didn't really have data to support it yet. However, we have now expanded that, and there have been several different publications supporting the notion of including microscopic NIFT-P as well as larger tumor entities. Within the United States, the thyroid tumor of uncertain malignant potential is not really utilized. However, it is used predominantly within the European community. And in essence, what this means is that there is some sort of irregularity at the capsule. There may be a projection that isn't quite classic for capsular invasion, and yet it's worrisome for it. There may be tumor cells that are immediately below an intact epithelium, but not really in a vascular space. And even though additional studies, levels, deepers, or special stains have been performed, you aren't quite convinced that it's either benign or malignant, and therefore in Europe the term of thyroid tumor of uncertain malignant potential has been utilized. Again, as I said, it's not really popular in the United States. There tends to be a use of either follicular adenoma with atypical features or something else, rather than necessarily using uncertain malignant potential. I would like to just highlight one of the reasons this causes problem is here you will notice 3 different needle points from a fine needle aspiration. As you know, the endocrine organs and specifically the thyroid are almost always evaluated with preoperative fine needle aspiration, sometimes more than one, depending upon what the findings are and whether molecular testing will be performed or not. And so with that, you really can get this remarkable proliferation, sometimes incorporation of neoplastic cells into it. But I feel that the vascular proliferation, the giant cells, the histiocytes, extravasated erythrocytes, sometimes, an abrupt point of separation where you can see where the needle actually came through and resulted in the findings that you have, are very, very helpful in saying, listen, this is not evidence of capsular invasion, and this is something that is part of a fine needle aspiration or core needle biopsy site change. For most of us with the electronic medical records, we're able to immediately access that and not have too much difficulty with being able to record that. I feel it's nice to incorporate it into the findings so that the clinician recognizes that you are using those results as part of your interpretation. But I also know some of you work in labs that are referral centers where that particular information is not necessarily available and therefore can be quite challenging at some times to be able to get that information. So from the malignant follicular cell-derived neoplasm category, and you will notice the follicular cell-derived is because this is not medullary thyroid carcinoma or salivary gland carcinoma or some of the other tumor categories. These are those that are follicular cell-derived neoplasms. They've kind of been 2 major changes. I think that it is not so good that the invasive encapsulated follicular variant of papillary was pulled out of papillary thyroid carcinoma. We spent quite a bit of time discussing it violently, and yet it is still in the book. So sometimes you don't always win and your opinion doesn't always count. But, just to say that it in essence is the malignant counterpart of NIFT-P. So in other words, if you have all of the features of a follicular patterned tumor, but there is either capsular or vascular invasion, while the nuclear features of papillary carcinoma are identified in an almost exclusive follicular tumor, it goes into that particular category. So you will see here there are several areas of capsular involvement where it has invaded into, through, and out beyond onto the other side of the capsule. The nuclear features of papillary carcinoma are very well identified in this regard, and certainly you can see that it is in a follicular pattern. I think this should have been kept as a subtype within papillary thyroid carcinoma rather than being pulled aside, but that is for the 6th edition to resolve, and happily they will do so. As you notice with papillary thyroid carcinoma, the term variant is kind of being eschewed. Part of the reason for that is variant is the terminology utilized primarily when there are molecular alterations that are present, and so to try and make a immediate separation between them, subtype has been utilized almost exclusively now, with the exception of the follicular subtype, where follicular variant is still used. And you can see here that the follicular variant terminology still is incorporated where it is not in any of the others. Now, I would like to point out that this was the exact same group that was used for the previous edition, but now I'd like to point out that cribriform morula variant is no longer considered a papillary thyroid carcinoma. It is considered a completely separate entity, as you know, related to Wnt and beta-catenin pathway abnormalities. And then, of course, microcarcinoma has also been removed as an entity. So even though microscopic papillary carcinoma is still something that we recognize as an entity, with anything less than 10 millimeters still being the criteria for it, it is now thought that these particular entities should be separated into whatever the subtype appropriate for them may be. So in this particular case, it would have been called a classical papillary carcinoma 1 millimeter in size, and that would obviously convey to the clinician that it was a microscopic tumor, but no longer is microscopic just its own category, irrespective of the underlying histologic feature that may be present. Oncocytic follicular carcinoma got its own category as well. Hürthle cell has been dropped completely and should not be present or used, since it is talking about C cells in dogs and therefore is not really related to this particular cytoplasmic change. When you look at it on high power, it has a very opacified eosinophilic appearance, many times associated with prominence of the nucleolus within the neoplastic cell nuclei. And as we all know now, this is of course related to deleterious complex 1 mitochondrial DNA mutations, and so it really is a very specific and unique finding. It is not just a follicular carcinoma that has oncocytic change. It really is a different driver, and therefore you won't have the same drivers that you see with RAS family mutations in this particular neoplastic condition. So going back now to the follicular cell-derived neoplasms is where I'd like to spend kind of the next 10 or 15 minutes or so. And the reason for that is the high-grade follicular cell-derived non-anaplastic thyroid carcinoma. Boy, what a mouthful. The endocrine pathologists love to have these exceptionally long names. But it is the high-grade category, and because it is follicular cell-derived, we wanted that to be part of the name, because obviously high-grade can be seen in salivary gland-type neoplasms. You can have high-grade in medullary thyroid carcinoma. You can have high-grade in some of the thymic-derived tumors that can present in the thyroid as well. And so it really was trying to highlight that it is a high-grade follicular cell-derived tumor that otherwise does not fit into anaplastic thyroid carcinoma. So having said that, there are actually two different subcategories within this follicular cell-derived carcinoma group, that of the poorly differentiated versus high-grade differentiated thyroid carcinoma. So these two tumor types do have different morphologic features, they do have different histologic appearances, and they also have different molecular drivers. They in fact have a slightly different overall outcome related to them. You'll notice I've included some of the PubMed ID numbers here, and I know that this is being recorded, so potentially you could go back and look at it if you wanted to. So I'm going to spend a few moments just discussing the criteria for, first of all, poorly differentiated. This particular category is the Turin criteria, which have been around for nearly 20 years now, based on a number of different features. So the architectural pattern is that of a solid trabecular insular growth, and that is required for the diagnosis. It needs to be the dominant finding. In other words, much more than 30% of the tumor needs to have these particular features in order to qualify. There needs to be an absence of the nuclear features of papillary carcinoma, and you will notice the very next thing says convoluted nuclei. So sometimes you do need to recognize that even though there is a convoluted nucleus that can be present, it doesn't have any of the other nuclear features of papillary carcinoma. It doesn't have a delicate nuclear chromatin. It has more of a heavy nuclear chromatin distribution. You don't really have true cleaves. So some of the other features that you have with papillary nuclear criteria are not present. And then either one of the following features with mitotic count, tumor necrosis, or the convoluted nuclei. So you will notice it's not only a pattern, but also a cytomorphologic appearance, and then by definition, of course, cannot have anaplastic features. Let me just highlight for a second, though, that these are invasive tumors. In other words, they grow out into the adjacent parenchyma. This is just a classical area of papillary carcinoma. And the reason I'm showing it is because, as you will see, it is involving skeletal muscle. And so quite frequently I get questions from people as to whether involvement of skeletal muscle on histology alone is sufficient to move it into a higher stage category, 3B. And the answer is no. It does need to be something that has been observed by the surgeon, either in their operative report or observed by the grossing pathologist or technician or technologist who's grossing it in to say that it is involving the strap muscles, or alternatively, if there was imaging evaluation and in the imaging on either ultrasound or CT, there was documentation that there was extrathyroidal extension into skeletal muscle. So this means that you do need to integrate your findings when you're reporting out thyroid neoplasia to make sure that the clinician's information or the imaging information is definitely part of your report so that you don't unnecessarily upstage a tumor just because you're seeing something histologically. Now, with the poorly differentiated carcinoma, it is a carcinoma by definition, right? So there's going to be invasion. Here you can see multiple nodules of invasion as they expand out, an area of vascular invasion where there is a thick-walled vessel that is completely filled with tumor. Another example here of that same vessel, just showing you that there is fibrin present within the clot associated with the tumor in a large vessel. Sometimes the vessels are quite small. This is just an example of a lymphatic where you will see that there is expansion of a lymphatic with a nodule of tumor. But either way, these particular lesions are definitely filled out into the adjacent either stroma, through the capsule, or through vessels. There are lots of different criteria to try and get to vascular involvement. I would like to say that if you are able to detect fibrin deposition in association with the tumor, in other words, it's formed a thrombus in the vascular space, then it's going to be sufficient to meet that criteria. So, here is just a little part of tumor. It is not actually in the vessel, it's between vessels. So you'll notice that there is a lymphatic on either side of it, and yet this is just a small piece of tumor that is dislodged. This is not evidence of either lymphatic or capsule invasion. Here you will notice another little island that has been entrapped. At first glance, though, you may say, oh, that looks like vascular invasion. However, when you go up to high power, you will notice now that the endothelium is intact and the neoplastic cells are underneath that endothelium, not yet invading into it. And certainly there is no evidence that you have any sort of fibrinogen response or fibrin deposition within the endothelial lined space. These are, much better examples where you can see that there is expansion of the lymphatic. They often will follow along the fibrous septa that are present within the thyroid gland. This is a nice example, again, of a vessel. You can see the smooth muscle out in the wall and then fibrin associated with it as tumor has invaded into and destroyed the endothelium of this particular vascular space. I think all of you recognize the architecture of poorly differentiated thyroid carcinoma because it does have this very characteristic insular trabecular architecture. It results in a really profound separation artifact. So you will notice this clefting type space artifact between the tumor nests and the adjacent parenchyma, or just between the various nests of tumor, giving a characteristic finding of these stretch marks in essence. And if you can find them, I think it is a very helpful finding, usually something seen on low power. Another example here where you can see the retraction artifact very easily identified in more of a insular architecture here, a bit more of a trabecular architectural pattern here, not quite the same retraction artifact, but instead you will notice that there are some open and patulous vessels. These patulous or hemangiopericytoma-like vessels, staghorn-type vessels, whatever name you like for them, are often quite easily identified in these particular lesions as well, and therefore give you a appearance to the architectural pattern. A bit more solid appearance here. So remember I said solid, insular, or trabecular. It's a combination of these particular findings that you utilize to come up with the pattern of growth. And then, of course, on higher power, you can see that there is still a follicular distribution. Colloid is being produced. You will notice that there are these isolated areas of colloid. Sometimes it's an incredibly small little dot of colloid, but it is still quite easily identified. Mitotic figures are usually easily seen as well, and here you will notice several mitoses in just this single high power field. And so with that, it is obviously sufficient to meet the criteria for both the pattern as well as, in this case, areas of increased mitotic activity. You will notice there's tumor necrosis in this example. It's a nice area of comedonecrosis. The ghost cell outlines are easily identified. And again, that very characteristic globular or dot-like colloid deposition. In fact, that colloid deposition can be highlighted with a thyroglobulin, as you can see here. And that thyroglobulin gives you a very nice little dot in the cytoplasm adjacent to the cells. And sometimes it really is quite limited. In other areas, it's a little more easy to identify, but it is quite characteristic for this particular pattern of the poorly differentiated thyroid carcinoma group. Now, when one talks about tumor necrosis, I've kind of shown you classic areas of tumor necrosis. I would like to identify that sometimes it's quite limited. You will notice the small area on the lower portion of this field highlighted with the arrow, where you can just see the ghost cell outlines. Another example here where you can see several ghost cell outlines in this particular pattern. It's kind of a trabecular architecture here. But again, sometimes it may be confused with blood or hemorrhage or degeneration. So you do need to sometimes go on to higher power in order to be able to confirm that in fact you are dealing with true tumor comedonecrosis. So let's now transition to the high-grade differentiated thyroid carcinoma category. In this particular entity, you'll notice the same thing with the architectural nuclear necrosis and mitotic figures, and then, of course, no anaplastic features. But because it is a high-grade endpoint, it can be identified either in a papillary thyroid carcinoma, a follicular thyroid carcinoma, or potentially even in an oxyphilic thyroid carcinoma. So any one of those particular tumor categories can have this as one of the findings, and therefore the nuclear features can be quite varied and any one of them can be present. The criteria required for this diagnosis is one of two things. Either the presence of a mitotic count that is greater than or equal to 5 mitoses per 2 square millimeters, and if you want to just extrapolate that to be 10 high power fields, it's probably a good extrapolation. And then tumor necrosis. So it's one or the other. I can tell you that the tumor necrosis is the much more frequently identified criteria than is the mitotic count. Frequently they will be seen together, but if only one of them is present, it's much more common to have tumor necrosis present than to have just isolated, markedly elevated mitotic index. So again, these are carcinomas. So here's an example of an oncocytic carcinoma, but just showing you that it is widely infiltrative out into the adjacent parenchyma. Here it is invading through its capsule in a mushroom-like architectural appearance. But again, vessels will be involved. Here you can see that there are multiple vessels. In this particular case, a nice lymphatic with endothelial lining and seeing the presence of fibrinogen. So let me just talk about the notion of highlighting this particular feature. I do not ever use any vascular markers. So I can tell you in the 30 years, I don't use CD31, CD34, factor 8, ERG, F1, Fly1, any of these. I just find them to be completely useless. Why is that? Well, if you think about the endothelial lining of endocrine organs, this is something where you are responding to the fight, flight, or freeze response, and it needs to be instantaneous. So if you're waiting for your hormones to get into the system and then kick around with your blood system and finally you're like, oh, that was a snake, this is too late. So it is a open, fenestrated area of endothelial lining so that the hormones are able to get through immediately. And so this means that if you're looking at a discontinuous endothelium already, and now you're trying to identify If it's discontinuous because the tumor has broken through at that point, you're really going to be very, very challenged to interpret endothelial markers. However, as I mentioned, fibrin is a common finding. CD61 is expressed on platelets as part of the intravascular tumor cells, and it's related to the fact that they are part of the fibrinogen cascade. So sometimes your department of hempath will already have CD61 available. You will notice that in each of these illustrations, you can see that there is CD61 positive platelets immediately associated with the neoplastic cells. So this is what is meant by a thrombus. The same thing over here, the neoplastic cells are immediately adjacent to it. I will say, though, that you can have intravascular fibrin without any neoplastic cells associated with it for a different reason. So it is not always just, oh, great, it's there and therefore it's going to be positive. But if you definitely want to try and do some sort of vascular marker, this would be the one that I would recommend doing. Again, an example of vascular invasion, just highlighting in a smooth muscle walled vessel here. So let's go now to the tumor. Here you can see a papillary thyroid carcinoma, large swath of necrotic material in the center, therefore meeting the criteria for a high-grade differentiated follicular carcinoma. Another one here, papillary carcinoma with lots of areas of tumor necrosis. Highlighting that when you look at it on high power, you can see lots of different patterns of growth within the neoplasm. Not every one of the nuclei are going to be the same. You can have different solid versus follicular patterned areas or even papillary architecture. Here you can see an area of comedonecrosis in a papillary carcinoma where multiple different patterns of growth are identified again. Sometimes the sheet-like distribution can take on a more solid appearance here, but you will notice this definitely still has the nuclear features of papillary carcinoma very well developed in the rest of the neoplastic cells. Sometimes the tumor necrosis can be quite subtle, as you can see in this area, where it just gives you an outline of necrotic tissue where all of the rest of the neoplastic cells can show a solid to even follicular architecture. And I will say, when I look at papillary carcinoma as an entity, quite commonly there are multiple different patterns. So when on low power I see multiple different patterns of growth, my index of suspicion for papillary carcinoma is certainly going to be elevated. And in this case, with this kind of solid to insular architecture focally, even though there is papillary architecture, I'm going to be worried about high-grade transformation in this neoplasm. The central area here has undergone necrosis, and so you will notice several necrotic cells in the center. However, it is not always a profound finding. It may be quite limited, as in this example of a hobnail subtype of papillary carcinoma that has areas of comedonecrosis. Other areas are a little bit more obvious, where the ghost cell outlines of the neoplastic cells are present, sometimes even with the nuclei still being maintained, in this example of papillary thyroid carcinoma. Now let me go on to follicular carcinoma. That same tumor can undergo the same high-grade transformation. Here you can see the ghost cell outlines of the neoplastic cells, and therefore would be true comedonecrosis. Another area of necrosis present in the lower corner here of otherwise a follicular carcinoma. I'm not highlighting the areas of invasion just to highlight the areas of necrosis. And then oncocytic carcinoma related to, the abnormal mitochondria can also have these same features. This tends to be a little bit more solid here. You'll notice 3 mitotic figures just in this single high power field, and certainly met the criteria for having 5 or more. And then you will notice the areas of early necrosis over here, much better and more well-developed necrosis in the central portion of the field. Now, let me just say, sometimes the necrosis is not so obvious. Here is an area of pycnosis. This is not yet area of true comedonecrosis, but if I see something like this in several areas, I'm either going to do a few deeper levels, or perhaps I'll submit additional sections. I'll go back to the specimen myself. Sometimes the tissue techs or the pathology assistants will specifically avoid areas of necrosis to submit because they think, well, it's dead, so you don't want to see that. You'd like to see the areas that are viable. And so you go back and you realize, oh goodness, the entire center of the tumor is necrotic. Let's submit a section from that, and now you're able to identify an area of true necrosis. So whenever I see areas of a lot of pycnosis in the tumor, my index of suspicion that there's going to be areas of true necrosis somewhere elsewhere in the tumor is certainly elevated. The exact same thing with histiocytes. So, this is kind of a clue when you're looking at endometrium as well. You see these kind of histiocytes in endometrial carcinoma. The same idea here. If you have a lot of histiocytes all aggregated together, you can see that they're kind of the dead nuclei of some of the neoplastic cells present within them, but it isn't quite as classic and characteristic. So again, if this is a finding that I have, I'm definitely going to look at other sections, look more carefully and closely to find perhaps smaller areas of comedonecrosis in the tumor in order to be able to accurately classify it. Now, when you think about the molecular drivers, I'd indicated that poorly differentiated carcinoma actually is a different category, with most of them defined by a concurrent presence of RAS and TERT promoter mutations, with a variety of other mutations present as well. You will notice that in the poorly differentiated carcinoma category, however, BRAF V600E only accounts for about 6%. However, if you now go to the high-grade differentiated group as a point of comparison, this really has a much higher association with BRAF, and the only reason for this is papillary carcinoma is, of course, the most common neoplasm of the endocrine organ system, and therefore papillary carcinoma is going to be more frequent, and therefore more frequently undergoes high-grade transformation as well, and quite often it is related to a TERT promoter mutation. Let me just say at this particular point that many of you do molecular testing on your fine needle aspirations, and you'll come back with results. Hopefully, you are not using something that comes back as suspicious only, because that is somewhat of a useless test. I'm not going to give the name. I think you all know it already. However, if you're using something like Thygen Next or Thyroseq, whether it's version 1, 2, or 3, any of these other products actually tell you what the gene is, what the particular mutation point is, what the allelic frequency is, so you have a real concept of what it may be. And in those particular tests, they will identify TERT. And I can tell you so far, with one or two exceptions, TERT promoter mutation is almost invariably associated with a more biologically aggressive behavior in a tumor. And therefore, total thyroidectomy really is the thing to do for patients that have a TERT promoter mutation in a thyroid nodule. So I think this is a significant thing to recognize. When you see TERT, you need to go back and look at that tumor, submit more, put in the entire periphery, do something in order to be able to document the fact that you are in fact dealing with a carcinoma rather than with a benign lesion. So with that caveat in mind, I like to kind of put things a little bit in perspective. This is a fantastic painting by Caravaggio, and you may say, well, what has the crucifixion of St. Andrew got to do with thyroid carcinoma? Well, it's if you look at all of the characters, right? So this little dude here in the bottom, let's look at him on higher power, and you'll notice he has this gargantuan goiter, and I am sure it's anaplastic thyroid carcinoma, and he was dead before the painting was hung. So now if you go into anaplastic thyroid carcinoma, the only real change with this particular category was squamous cell carcinoma is no longer considered a separate entity within the thyroid. All of them are considered to be just subtypes of anaplastic thyroid carcinoma, since they often have the same molecular signatures, and of course also have the exact same dismal prognosis, and therefore combining them into a single category is worthwhile. You can see that there is squamoid differentiation in this area with a sheet-like architecture, but clearly anaplastic cells, lots of tumor necrosis. They tend to lack thyroglobulin as well as TTF1, but they will be positive with PAX8. So in this case, it's a nice example of still being able to maintain thyroid derivation for the neoplasm rather than necessarily representing either a metastasis or perhaps a mesenchymal or hematolymphoid lesion. I would also like to just highlight for a moment that thyroblastomoma was introduced in this book as a new entity. It is specifically because it is a high-grade embryonal type thyroid neoplasm, but it does have primitive thyroid-like follicular structures, and then, of course, small cell as well as mesenchymal stromal component of varying degrees. This used to be considered to be a malignant thyroid teratoma, but since many of these cases thus far tested have shown to have DICER1 variants present within them, thyroblastoma, in matching the blastoma categories used throughout the rest of the body, seem to be a more appropriate terminology for it. I think all of you probably have seen one or two in your career where it does have almost a primitive cartilaginous type material, very, very primitive small blue round cell appearance in the background. You will notice some follicles being created of primitive thyroid epithelium with this very, very profound and often completely undifferentiated spindle to epithelial compartment in the background. These cells have varying reactivities, but with SAL4 being one of them, a very nice example that can be seen in this tumor, while highlighting the follicles with TTF1 and the background mesenchymal cells with desmin. So with that, I'm going to end the endocrine part of the lecture, and I'm going to go over to the head and neck book. And just so you know, we did actually have fun with this, even though it was often at the most ungodly hours of the day. And you can see that obviously I was the one having the most fun with this. As I cracked the whip and, set out bolts of lightning. But I do want to point out the time at the very bottom, in the bottom side, it's 2 a.m., right? So let me just say it's 2 a.m. somewhere because, each of us were in a completely different time zone. And for me, I actually started at 11 p.m. and went through until 1 p.m. of the following day. So I did have a 2 p.m. for me, but it wasn't at the end of the meetings. So let me now transition to the head and neck book, and I'm going to talk specifically about the neuroendocrine lesions in that location. As you can see, 288 authors, 253 entities in 35 different countries represented. The same aggregation phenomenon was attempted. So, all of the salivary glands are just presented in one location. Same thing with soft tissue lesions. All of the bone tumors were grouped under the odontogenic and maxillofacial, and then a completely separate chapter on the neuroendocrine tumors and paraganglioma were presented in this book, different from what had been done previously. And again, those genetic tumor syndromes that had specific manifestations unique to head and neck pathology were presented in this book. So, here's the entire grid of all of the books that are available out there. This time we're going to talk just a little bit about the head and neck area. And again, the idea of linking through and the whole slide images and tables that are visible are fantastic. The print book is actually 2 volumes, so it is somewhat a bit unwieldy to use because you're never sure which section is in which area of the book. But nonetheless, it definitely is out. So if you look back through the previous editions, the number of diagnoses is actually decreased, and this is because of trying to harmonize between them, and specifically the idea of having neuroendocrine neoplasms as a group, separated out into neuroendocrine tumor as well as neuroendocrine carcinoma. And as you can see within the neuroendocrine tumor, grade 1, 2, and 3, neuroendocrine carcinoma with small and large cell as well as Merkel cell, and of course the mixed neuroendocrine, non-neuroendocrine category is present as well. But this really is one of the single most profound changes within the head and neck book. And so let me just take a couple of moments to talk about those. As you know, the neuroendocrine tumors are well-differentiated epithelial lesions that arise in the upper aerodigestive tract somewhere and or in the salivary glands, that are arising from the dispersed neuroendocrine system. There has been a remarkable improvement in imaging technology over the last several years, and specifically the somatostatin receptors that are identified by the dotatate PET-CT combination with gadolinium. And I think this is really one of the most useful things in both localizing, staging, and potentially even treating these patients with the somatostatin receptor inhibitors. Sometimes the neuroendocrine tumors within the head and neck area will have hormone excess, but not nearly to the same extent as they occur in other anatomic sites. So here are just a couple of examples of those dotate gadolinium PET-CT combinations, where you can see that it really beautifully highlights areas of either multifocality or tumor metastasis. This is one of the most significant findings that allows for easy management with those particular lesions. So with neuroendocrine tumors, I think we all recognize them, right? So the choroidal trabecular-like pattern, small nests, varying amounts of pale cytoplasm surrounding these relatively monotonous nuclei that have typical salt and pepper nucleochromatin distribution. So I feel that that particular setting is one that we all recognize, but as you know now, they should be separated into grade 1, 2, and 3 based on a mitotic index using less than 2, 2 to 10, and greater than 10 mitoses per 2 square millimeters, and then the presence or absence of tumor necrosis variably being present. Certainly in grade 3 it is usually present. Now, the Ki-67 labeling indexes for these with the same kind of general concept of less than 2%, 2 to 10%, and greater than 10% have been utilized, but this still remains to be effectively applied to all of the neuroendocrine tumor categories within the head and neck space. I do feel that especially in the higher grade lesions, such as a grade 3 lesion, it's important to use the Ki-67 because if there's any sort of crush artifact or it's a small tumor size or there's very limited a number of nuclei, you do want to make sure that you aren't potentially putting someone into a higher grade tumor that may require more aggressive management. As you would expect from the immunohistochemistry, either CK-pan7 or CAM5.2 is present as one of the epithelial markers. And then whether using the traditional markers of synaptophysin or chromogranin or using more of the current ones that are transcription factors like INSM1, serotonin, calcitonin, etc., certainly can be utilized as well. One of the things about neuroendocrine tumors as a whole is that they have an intact p53 and an intact retinoblastoma gene or RB. This is very significant again when you're using the separation of a grade 2 or 3 lesion from the potential of a small cell or large cell neuroendocrine carcinoma because they are lost in the small cell carcinoma and large cell carcinoma category. So if you're struggling with the case, I do feel that performing retinoblastoma and p53 will allow you to make that particular separation. Let me just show a few examples here. Here is a laryngeal grade NET1, where you can see it has the classical features of a neuroendocrine tumor, very nicely arranged in kind of these open gland to festoon-like appearances, a bit more of a organoid appearance in this example from a grade 1 tumor. Here is an example now of a grade 2. It has infiltrated out into the adjacent stroma, but not quite having the profound nuclear pleomorphism yet. A little bit more pleomorphic in this example, and certainly getting that way in this example of a grade 2 tumor. However, here you will notice that there are mitotic figures now, and of course the presence of tumor necrosis. So again, you can see that this would qualify into the grade 2 neuroendocrine tumor category. And then, of course, as you get into grade 3, sometimes separation from small cell or large cell neuroendocrine carcinoma can be challenging. In this case, there are a myriad of mitotic figures just in a single high power field, and of course the presence of tumor necrosis about the center, as you can see in this example here, where there are several mitotic figures, including atypical forms in this example of a grade 3 neuroendocrine tumor. As you know, they will express CK-pan. It should be a strong and diffuse cytoplasmic reaction, not necessarily in a dot-like pattern that you see in small cell carcinoma. Chromogranin should be positive, and of course synaptophysin may be as well. The chromogranin is a little bit more sensitive than synaptophysin. Aberrant expression can be seen with calcitonin as well as with TTF1, so a whole variety of different markers can be seen in these neoplasms and don't necessarily give you a lineage or point of origin for these tumors either. The reason I'd shown the TTF1 and the calcitonin for a laryngeal lesion is several of the grade 2 and grade 3 NETs will co-express these markers and have nothing to do with medullary thyroid carcinoma, even though the thyroid is immediately adjacent topographically. Just to highlight that the retinoblastoma is in fact intact, so all of the nuclei are positive for it and therefore would help you to exclude a small cell or large cell neuroendocrine carcinoma category. So we all know what small cell neuroendocrine carcinoma looks like. There's no difference in the criteria here. The vast majority of the neoplasms occur within the larynx in the head and neck, although about a third of them do occur within the sinonasal tract as well. And as you would expect, there is a strong tobacco association. However, within the oropharynx, it can be associated with high-risk HPV, even though smoking is also concurrently present in many of those patients. So the histologic features need to have neuroendocrine differentiation identified histologically. You do need to see something histologically to trigger you and not just rely on the immunohistochemistry alone. With small cell carcinoma, the fact that it does have such a limited amount of cytoplasm and indistinct cell borders means that crutch artifact is quite frequently present, and therefore it may be quite challenging, especially when you're trying to do something like a mitotic count on these particular tumors. So here is a nice example on intermediate power. You can see just large nests and islands of these neoplastic cells that are molded against one another, showing a very high nuclear to cytoplasmic ratio surrounding the vasculature in this example, whereas here you can see that more characteristic crush artifact that is so easily seen within them, and therefore makes interpretation of both the histologic features as well as immunohistochemistry quite challenging. However, you can generally identify areas that are a little better preserved, as you will notice in this example, where generally there tend to be chromocenters, not really very prominent nucleoli, although an isolated one here or there can certainly be seen. As you would expect with a neuroendocrine carcinoma, you're going to have epithelial markers as well as neuroendocrine markers with aberrant expression of some of the others, like TTF1 as an example. And in this case, again, the idea that there is global retinoblastoma loss in neuroendocrine carcinomas is a very, very helpful feature in coming up with the diagnosis. Now, let me add that P16 is not a good marker for HPV as a lesion within the head and neck, because neuroendocrine carcinomas will have P16 expression irrespective of HPV status, and therefore you do need to do in situ hybridization related studies to confirm that particular finding. Still not as yet well expressed, but certainly Ki67 labeling indexes are usually way greater than 20%, and in fact, most of them seem to be in the 70 or 80% range, so nearly all of the nuclei will be reactive when you do a Ki67 in these cases. So with small cell carcinoma, there tends to be a more paranuclear dot-like distribution. You can still see that there's cytoplasmic and membrane reactivity, but that dot-like pattern can be quite easily identified. There is going to be a lack of P40 and a lack of CK56, the usual markers that you see for squamous differentiation, which would help you with interpretation as well. A nice strong reaction with synaptophysin, again showing a little bit of a highlighting of that paranuclear dot-like reactivity pattern, while INSM1 gives you a very strong and diffuse reaction as one of the second tier in the neuroendocrine field. Aberrant expression again can be seen with TTF1, but the most profound thing that you can look for is that constitutive loss in all of the neoplastic cells of retinoblastoma. It is still expressed in endothelial cells or fibroblasts in the background, but this particular remarkable loss in all of the nuclei is a very, very helpful feature to confirm the presence of a neuroendocrine type carcinoma. Here you'll see a very strong and more than 80% nuclear reaction with Ki67 to suggest that nearly all of the nuclei are in some sort of mitotic action. And then just to highlight that this is an example from the oropharynx, where the RNA in situ hybridization for high-risk HPV is certainly positive and is expressed quite profoundly. So I don't usually do P16 per se, but in certain anatomic sites like the oropharynx, if there is a neuroendocrine type carcinoma, doing the high-risk RNA-ish may be helpful to suggest an etiology for those particular lesions. As you can tell, neuroendocrine carcinoma in the small cell, small blue round cell tumor category within the head and neck has a different pattern of involvement than with other immunoreactivities, and therefore can be quite helpful when you're looking at including and excluding several other lesions within the differential diagnostic consideration. Large cell neuroendocrine carcinoma just has the same overall features, except it tends to have very vesicular chromatin and prominent nucleoli, which is why it may end up being associated with other lesions in the differential, like a sinonasal undifferentiated carcinoma, or perhaps even olfactory carcinoma, and some other lesions within the upper aerodigestive tract space. Sort of by definition, the IDH2 mutations have not yet been resolved. They can be seen within large cell neuroendocrine carcinomas, but they also can be seen within other neoplastic categories as well. And so at this particular point, just the identification of an IDH1 is not yet putting it into its own tumor category, as we have done with the SWE/SNF complex associated deficient tumor category, whether it's SMARCB1 or SMARCA4. And since that is part of the SWE/SNF complex deficient sinonasal carcinoma category, if SMARCA4 or SMARCB1 is present in a tumor, it goes into that category, even though neuroendocrine differentiation may occasionally be seen within this particular neoplastic category. So just recognize that that is still something that certainly needs to be considered. Again, it's going to have a very similar immunophenotype to what I said with small cell carcinoma, but here it has a much more open nuclear chromatin distribution. Tumor necrosis can easily be identified, and very prominent nucleoli are quite frequently seen, and therefore you can tell how the differential with a, for instance, sinonasal undifferentiated carcinoma can certainly be present. CAM5.2 is one of the markers, is strongly expressed in large cell neuroendocrine carcinomas, INSM1 giving you a nice strong reaction here as well. Now, let me transition kind of a little bit away from that, but just to highlight some of the other neuroendocrine tumor categories. As you know, pituitary neuroendocrine tumor, or PITNET, is the new term for pituitary adenoma. This can develop within the sphenoid sinus as an ectopic lesion, and as you know, here is the sphenoid sinus, and it's immediately below the sella, and therefore tumors from the pituitary can certainly present in that anatomic site. Here you will notice radiographically how it's really nicely presented within the nasal cavity, and quite frequently it's an ENT surgeon who's doing the overall surgery, and therefore if it were coming from a neurosurgeon, you may have a slightly different viewpoint of where it is that they're presenting the material from. As you all know, pituitary neuroendocrine tumors, or PITNETs, are no different. It's just that you're seeing them in a slightly different location within the sphenoid. They have all of the both epithelioid quality, of wide variety of different presentations to the neoplastic cells. Profound pleomorphism can be seen, including tumor necrosis, but in general, there's no perineural or lymphovascular invasion, and you also do not have atypical mitotic figures. So this is one of the categories where you can kind of make a separation as you're looking at these particular lesions. So they can be quite polypoid in their presentation. The usual appearance below an intact respiratory epithelium of this neuroendocrine solid appearing tumor pattern, a little bit more palisaded away from the vessels, can be seen in an example like this. You will notice that there is clearly bone involvement as it invades down from the sella. Tumor necrosis can certainly be seen in these neoplasms as well. Sometimes it's a little bit more of an organoid appearance here, with little balls of neoplastic cells between a edematous stroma. Sometimes it's really difficult to identify when you have these individual neoplastic cells set within a heavy fibrosis, and often these are missed and called chronic inflammation without recognizing that in fact it is a tumor present in that location. We're all more familiar with the characteristic appearance where it has a trabecular to kind of insular architecture. Another example here where there is a pseudo-rosette type formation with very well-developed powdery salt and pepper nuclear chromatin distribution. I will add, though, that you can really see quite profound nuclear pleomorphism in pituitary neuroendocrine tumors, and so don't let that discount you away from the underlying diagnostic category. I think, as you know, with the same complex that you can do with these lesions. It's important to recognize that all of these particular neoplasms are now separated out based on the transcription factor, whether it is PIT1, SF1, or TPIT, before going any further through the multiple other hormones that may be produced by these particular tumors, whether they are primary in the pituitary or if they are in an ectopic location. So here is a strong and diffuse nuclear reaction with PIT1. This is by far and away the most common one that you're going to do. So if you're trying to bring on these particular findings in your lab, bringing on the PIT1 is certainly going to have the highest yield. As you can tell, all of the somatotrophs and mammotrophes, lactotroph, thyrotroph, the pluripotential acidophilic stem cell, all of those are covered by the PIT1 lineage, and therefore can be quite helpful in being able to document pituitary origin for these particular neoplasms. As you know, they are going to be reactive with epithelial markers, as I've illustrated here with CK-PAN, and then with a variety of different neuroendocrine markers such as synaptophysin or chromogranin, recognizing that specific pituitary hormones will be present, often co-expressed, so multi or pluripotential can be seen in these lesions as well, but recognizing again that it needs to have both neuroendocrine features histologically and then neuroendocrine and epithelial markers present to be able to qualify as a pituitary neuroendocrine tumor. So here you will notice prolactin, just to highlight one of the findings with a PIT1 lineage tumor in this example. Now, I'm not going to talk about ear tumors specifically other than just to highlight the one that is in this space, the middle ear neuroendocrine tumor, or MENET. I think, as you all know, there are probably more names to this tumor than there are actually ever tumors that have been described. And I've put up a whole bunch of the names that have been used for this, including one that I added, which was NAME, neuroendocrine adenoma of the middle ear. So, there have definitely been a whole host of them over the years. Suffice it to say that they present usually with unilateral hearing loss and dizziness. Most of the patients will have incorporation of the middle ear bones into the lesion, as you can see here, and therefore the ossicles often need to be removed, which means you're going to render the patient deaf in that side for this particular tumor. It usually gives a bulging tympanic membrane that is quite characteristic as well. There's usually no serologic evidence of any type of hormone production or paraneoplastic syndrome. This may be because it's a very small lesion. There have been a couple of exceptions in the literature, but they don't really relate to the biochemical findings, and they don't talk about symptom changes when the tumor was removed, so you wonder if it is actually related or not. There are a whole host of different patterns of growth, and I think this is the thing that you need to remember when you're evaluating these tumors, that they're just a whole bunch of different patterns of growth. And that needs to be highlighted. The keratins are going to be positive, as well as neuroendocrine markers, and there are a variety of different co-expressions like islet-1 or INSM1 or SATB2, glucagon, pancreatic polypeptide, serotonin, the SSTR2A. Some have even co-expressed CDX2 or GATA3. So just recognize that this is definitely a neuroendocrine tumor and fits appropriately within the neuroendocrine tumor grade 1, 2, and 3 category based on labeling index, and so far the vast majority of these are grade 1 tumors. They have a very complicated overall growth pattern. Multiple different patterns of growth can be seen within them. They will often invade into the ossicles of the middle ear, and therefore you can really see that there is genuine bone involvement by this neoplastics proliferation. Plasmacytoid type appearance to almost rhabdoid appearance can be seen within them, a more glandular type appearance, and in fact sometimes that glandular area, you will notice that it has an inner lining epithelium that I'll show you is highlighted by a PAN cytokeratin or CK7. So there definitely is still a dual appearance to this. So the name of adenoma was probably not so wrong, and maybe this should actually fit into the mixed epithelial neuroendocrine and non-neuroendocrine category, but at least for the time being, the MENET category is being utilized for this tumor that shows characteristic nuclear distribution of neuroendocrine type features. They really can be quite profound and easy to identify, and so it's not usually a diagnostic dilemma. It can certainly be on frozen section, however. where when you look at it, you're like, wow, that looks like an infiltrative tumor. And of course, it is going between fibrous connective tissue, but it is a neuroendocrine neoplasm nonetheless. So here is what I was mentioning about the inner luminal lining cell appearance. These often will co-express one of the neuroendocrine markers, however, so it probably is just an epithelial differentiation that it's a little bit more profound. They are not going to be reactive, however, with any of the epithelial markers of squamous differentiation, so P63 as an example is negative, strong and diffuse reaction with synaptophysin or chromogranin, and then a whole host of different things like glucagon and islet 1, and then of course SATB2 giving the hindgut differentiation that can be seen with this particular neoplasm. And then finally, the SSTR2A can be used to highlight this as well, again related to somatostatin receptor, so imaging studies can be performed as well as potentially using treatment alternatives for these patients. I'll end now with paraganglioma because that is, of course, one of the things that can be seen in this location as well as a non-epithelial neuroendocrine tumor from the autonomic nervous system. Same reactive pattern can be seen with the dotate PET-CT. But just remember that this is one of the most commonly inherited tumors, with germline mutations specifically identified within the head and neck space within SDHD and SDHB, while SDHC is not nearly as common. And then, of course, associated mutations within either VHL, RET, or NF1 have also been identified. And so you will notice the neuroendocrine markers, GATA3, tyrosine hydroxylase, and dopamine hydroxylase can be seen with the sustentacular compartment identified around either S100, GFAP, or SOX10. Any one of these three markers can be utilized. And then, of course, SDHB is a nice immunohistochemistry to perform to highlight about, nearly 50% of all of the paragangliomas are associated with the germline mutations in succinate dehydrogenase as a whole. So it's a nice screening method for that. So you will notice that there is a bilateral tumor in this right at the carotid body bifurcation. You will notice that it is also highlighting additional tumors in this particular patient when one of the AVID studies is performed for this lesion. One of the few tumors in the head and neck that does have embolic material introduced, and so here you can see a nice example of embolic material adjacent to paraganglioma. So really, whenever I see embolic material, I know that they're thinking about either paraganglioma or potentially an angiofibroma of the sinonasal or nasopharyngeal tract area. Classic Zellballen type architecture for these lesions with a very characteristic supporting framework highlighted in this case with the S100, showing you an example of a strong cytoplasmic granular reactivity with tyrosine hydroxylase, and then also just to highlight that the SSTR2 is strongly and diffusely positive, giving you part of the reason why they react so nicely with the imaging studies, but also why potentially targeted therapy can be addressed to these lesions that are otherwise sometimes surgically impossible to remove. As I already mentioned, GATA3 can be positive in these tumors as well. And so GATA3 is not just for salivary gland or breast-related lesions. It can be co-expressed in other tumors as well. Just highlighting the SDHB loss, you will notice that there is no reactivity in any of the cytoplasm of the neoplastic cells. However, it will be constitutively expressed in the vascular supporting framework or in the background fibroblasts, and therefore you would still have a good internal positive control. I will just highlight again the neuroendocrine tumors of the oropharynx, when they are present, are usually HPV associated, and again, their synaptophysin and P16 would definitely be positive. And then I'm just going to throw out there that, olfactory neuroblastoma, right? This is a neuroendocrine type tumor. We have not yet tried to redefine it. It doesn't really have epithelial differentiation, except sometimes there may be a little bit of epithelial reactivity in the background, but it is still one of these neuroblast type tumors. But, potentially is this a olfactory net or an olfactory neck? Who knows if that is going to pan out to be the case or not. Not a lot of the original work has been performed on this to be able to correlate the findings, but we all know that they are very strongly associated with both chromogranin as well as S100 in a nice supporting sustentacular framework distribution. So at this particular point, my highlight for thyroid tumors is look for necrosis and do mitotic index. This is probably one of the most important things you can do, and it's often a very limited amount of tumor necrosis, but when it's present, you are going to have a worse overall outcome for those particular patients, and therefore you do need to highlight that it has moved it into a high-grade differentiated thyroid follicular cell-derived tumor category. The standardization of nomenclature for all of the neuroendocrine neoplasms, specifically around neuroendocrine tumor and neuroendocrine carcinoma, is still in evolution, but the grade 1, 2, and 3 for NETs and the small cell, large cell, mixed epithelial neuroendocrine, and non-neuroendocrine, as well as Merkel cell carcinomas, are certainly still within this particular differential as well. And so with that, I'll end the discussion.